Okay, this is chapter 3, the second part from the 11th edition of the textbook of radiographic positioning and related anatomy. So the last time we talked, we had finished with a supine and prone abdomen, and this kind of picks up on page 117 in the chapter. What we're going to be looking at is the rest of the abdomen positions, which tend to be an upright or an erect abdomen, a decubitus abdomen, which could be a lateral decubitus or a dorsal decubitus, a lateral abdomen, and an acute abdominal series. So let's get started with this. This is from page 117. And you will probably first notice that the picture on this PowerPoint is different from the one in the book, and that was done on purpose. This represents the same image as figure 3.36, but honestly, in the book on page 117, 3.36 is extremely confusing. They have a female patient with her back against the board. Her head would be to the right of the page as you're looking at it, and her feet to the left. But they have a blanket over her legs. She has gray pants, a green leotard, laying on a blue mattress with a shield over her breasts. So what the picture gives you, it's really hard to place that unless you know what they're doing. So I feel like this one does a much better job. Now, notice we said with decubitus, they are called by the side down, and decubitus implies a horizontal beam. So a left lateral decubitus position of the abdomen means that the patient's left side is down, and the beam you can see here represented by this pointer is horizontal. So some of the reasons they might order this, this would be done in place of an erect abdomen if the patient was non-ambulatory. They can look for any abdominal masses, they can show air fluid levels, and any accumulations of intraperitoneal air would be demonstrated. On this particular image, not sure why that popped up, on this particular image, the patient you can see is on their side. So when we talked about decubitus chest, we said they had to be on their side a minimum of 5 minutes. That's the same for this. I will tell you that 10 to 20 is actually preferred because that will best visualize any small amounts of intraperitoneal air. There's more to layer out in the abdomen than there is in the thorax. And typically they order a left lateral decubitus, or we do that, because if the patient's lying on their left side, then if there was any free air, you would visualize that between the liver and the right hemidiaphragm. If they were laying on their right side, the problem becomes you could mistake free air with the gastric bubble, because air would rise if the left side was up. So typically a left lateral decube, if it's going to demonstrate any free air, it'll be found between the liver and the right hemidiaphragm. The technical factors for abdomen are still 40 inches, a 14 by 17 IR placed either portrait or landscape to the patient. Totally depends on how you would image that patient supine. You would do the same thing for this. So they would do her supine, and now they have this IR. It's portrait to the patient, but it looks landscape to us. The technique for this would be 80 at 12.5. And notice when you read this, it says the patient should lie on their left side. They do reference a minimum of 5 minutes. But the central ray should be at 2 inches above iliac crest and midline. So I gave you these arrows. That is where this line should be, is in between these arrows. 2 inches above her crest at midline. Anytime you're trying to demonstrate air fluid levels in the abdomen, your central ray would have to be 2 inches above iliac crest to demonstrate the diaphragm. So only an AP supine abdomen is at the crest, and that's only if it's one IR placed portrait. Once you go to 2 image receptors with overlap, the central ray kind of goes out the window. Hopefully between this lecture and meeting in class, that will make sense. So even though the picture in the book is super confusing, I feel like this is demonstrating, even though they're visualizing the CR at the crest, it should be 2 inches above the crest at midline. And the exposure is taken on expiration, just like all abdomen. And in decubitus positions, they're called by the side down, but they're marked by the side up. So this would have a right marker placed on the top side of the patient, because that would be her right side. And then you could annotate an arrow or the word decube. If done correctly, this should demonstrate bilateral diaphragms, and you should include both sides of the body. Now this you can see the top portion, but they seem to have cut off the bottom portion, and that is not ideal. You should include both sides of the abdomen. If that was how it was going to look, then they should have placed the image receptor crosswise landscape to the patient, which would look portrait to us. So bilateral diaphragms must be demonstrated, and then air-filled stomach and loops of bowel. And then you can see in this picture that air is rising towards the right side, and you can see this distinct line in there, which tells you that the patient was lying with this side down, and then air rises, fluid would fall. If the patient was ambulatory and they were looking for air fluid levels in the abdomen, in that free intraperitoneal air, then you could do an erect or upright abdomen. Now this is the same picture as in the book, figure 3.39 on page 118, and the central ray is demonstrated correctly at 2 inches above the iliac crest and midline. You can see the central ray is here. Here's the patient's crest, and then they are approximately 2 inches above the iliac crest at midline. They do reference that typically on a stenic patient, if this patient was to bring his arm out straight, the top of the IR would be right at about the level of the top of his axilla. And that's a valid point. Typically, if you are at the axilla, you are going to definitely get diaphragm, because remember, the light is deceiving. This image is actually going to capture from right up here all the way down here, right? So with this, it's the same thing, 40-inch SID, 80 kVp at 12.5 mass. Patient stands with their back flat against the wall bucky. Center the patient, and then place the central ray 2 inches above iliac crest. Now, this patient, they have one IR placed portrait. If the patient was to be done landscape, that would be acceptable as well. The only thing would be if you did it landscape and you felt like you didn't really have much of the abdomen, you could and would have to do 2 image receptors placed landscape with 1 to 2 inches of overlap. And just like on the left lateral decube, you want to demonstrate air-filled loops of bowel. The stomach should be present, and bilateral diaphragms, and as much of the lower abdomen as possible, but you do not have to get pubic symphysis. You can see we've got diaphragm on here. You can see that those are loops of bowel, and we know that the patient was standing up or erect because of this solid line that we see, and air is rising. We also use left marker on all of these if at all possible, unless it's a left lateral decube, which would force us to use the right marker. Next on page 119 is a dorsal decubitus. So a dorsal decube implies that there's a horizontal beam and the patient is lying on their back or on their dorsal surface. This would also show any abnormal masses or air fluid levels, but a lot of times with this, they're looking for aneurysms. An aneurysm a lot of times can be seen in like an aortic aneurysm. You could see that sometimes on a lateral lumbar spine, because a lot of times patients will come in complaining of low back pain, and when we do the lumbar spine imaging, you can actually see sometimes the aneurysm. So then they may order a dorsal decubitus to follow up with that. Can also demonstrate an umbilical hernia with this position. An umbilical hernia would be towards the umbilicus or the belly button. The patient should be lying on their back. Again, a minimum of 5 minutes just so that everything layers out. 40-inch SID, a 14 by 17. However you would do the patient, like she probably fits one IR placed portrait to her, which would look placed portrait to her, which would look landscape to us. If your patient was bigger than that, you potentially would have to do 2 image receptors placed landscape to the patient, which would look portrait to us. You want to place the patient, this one, she's probably lying on the stretcher and they've just put it in front of the chest board. So you would put the patient with their, whichever side would be easier, ideally against the chest board, and then you would adjust it so that the central ray was 2 inches above the iliac crest. Notice again in this picture and in the book, I will be honest, I feel like it's really hard to tell. On page 119, it should be, though, this central ray right here should be 2 inches above the iliac crest at mid-coronal or midline. Now, figure 3.42, check your book, because in mine it says dorsal decubitus and it says right lateral position. But if you look at that, the patient is definitely got her left side touching the board. So it should say dorsal decubitus left lateral position. So on a dorsal decube, you can still call it that, but it's marked by the side closest to the IR. So in this case, they should use the left marker. In the book, this one right here, she has her right side against the board, and you can see right here they have right marker. So she's lying in a right lateral dorsal decube. I know, it's a lot of words. Okay. The biggest thing is that the central ray in the book, it says horizontal to the center of the IR at the iliac crest and or 2 inches above the iliac crest to include diaphragm. That's really confusing. It really should just be 2 inches above because that's the only way you're going to capture the diaphragm. Notice under the anatomy demonstrated, the first thing it says is the diaphragm, and as much of the lower abdomen as possible should be included, along with air-filled loops of bowel and soft tissue detail. This is actually a good picture of the dorsal decube. You can see the lumbar spine right here. This is the back side of the patient. This would be their sacrum right here. And then this is their abdomen. So a lot of times they're looking for aortic aneurysms in the prevertebral or in front of the vertebrae. We're supposed to demonstrate bilateral diaphragm. Now, I do see it here, and I see it here, but honestly, this is cutting it a little bit close on that. The picture in the book is the same exact one, so I feel like it's pretty close on that. They could have, and they very well might have, just cropped this for purposes of the book, but it should be, you should be able to visualize more of the diaphragm on this and the anterior surface of the patient, the top up here. You should be able to definitely know that you see the top of the patient since air rises. On page 120, they are showing you a right lateral abdomen. Now, notice the difference now is that the beam is coming down from up above. It's not a horizontal beam. Beam is actually coming down perpendicular to the patient. But again, the central ray is not correct on this. So this one, they tell you could be looking for soft tissue masses, an umbilical hernia, and sometimes this is done to localize foreign bodies in the abdomen. So you would be at a 40-inch SID in this case, and in the book to the table bucky. Your technique on this lateral abdomen would be 80 kVp at 25 mass. And I don't think I said for the dorsal decube, I apologize, but the technique on the dorsal decube is the same, 80 kVp at 25 mass. I know it's a lot, but in both cases, the dorsal decube and this, gravity is going to pull everything down, but it's still going to be in the way of your image. It's not gonna help like with upright. At least gravity pulls everything down. In a way, this one and the dorsal decube both are going to place the bulk of the anatomy in the path of the primary beam. So 80 at 25. The central ray on this should be perpendicular, and it's at 2 inches above the iliac crest. Now, how do I know that? Even though the book is showing you incorrectly, along with this slide on the PowerPoint, notice under the anatomy, the very first thing it says is diaphragm and as much of the lower abdomen as possible. So, because this is not just a supine abdomen, the central ray, literally for every other image we do of the abdomen, besides an AP supine, so AP supine is different, but every other image, the central ray, if you're able to do it on one image receptor, should be 2 inches above the iliac crest at midline. Okay, if you can write that somewhere and commit that to memory, it's huge. So the book likes to show you these perfect small stenic patients, and even though the radiologists want diaphragm on a supine abdomen, the book and the registry say we don't need it. So that's why some people definitely would fit on one IR placed portrait. Since the radiologists want diaphragm on everything, it forces us to almost do 2 images of pretty much every single patient. But aside from the supine abdomen, all other abdominal views, the decubes, the upright, this lateral, all of them, if the central ray is asked, it's 2 inches above iliac crest at midline. The criteria, again, diaphragm is included. You can see where if, say this was a child or a young adult who accidentally swallowed something that was opaque, it would allow you to see the anterior and posterior aspect, meaning you could see exactly where it was in the abdomen, which sometimes is why they do this or what they're looking for. Some clinical indications for the last thing in this chapter. It's called an acute abdominal series. I try to tell you that sometimes they'll refer to this as an AAS. And notice that 2 letters are the same, 2 A's. That's because we do 2 abdomen views, and the S is different. So we do 2 abdomen views and 1 chest view. Okay, an acute abdominal series. Some reasons they might order that might be the patient they suspect has an ileus, which is a non-mechanical small bowel obstruction, or they could have mechanical ileus, which is the bowels obstructed from a hernia or adhesions. Ascites, I usually reference that as a doughy abdomen because the patient almost feels, their abdomen feels like pizza dough. It's where there's abnormal fluid accumulation in the abdomen, and sometimes when you touch the patient, your fingers will actually leave a mark in there, like when you put your fingers in pizza dough, it kind of indents and then stays there. The same thing can happen when there is fluid accumulation in the patient's abdomen. They could potentially have a perforated hollow viscus, like maybe the bowel is perforated, or the stomach, maybe they had an ulcer that ate through the lining, and that would cause free intraperitoneal air. They could have an intra-abdominal mass, or sometimes they will do it post-operatively for abdominal surgery if the patient's having a lot of pain or experiencing a lot of bloating, and they're just checking to make sure that everything is okay. Now, anytime that they order abdomen and there's one view that would be considered erect, that should be done first. All of our erect images should be done first because it's most likely the case that the patient, if they're ambulatory, they've probably been sitting somewhere, whether it's on a stretcher or in a chair, maybe in the waiting room. They've probably accomplished the 5 minutes excuse me, of upright that's needed, excuse me again, for these images. So anytime there's something ordered like an AAS on an ambulatory patient, would be a PA chest, an upright abdomen, and a supine abdomen. So if I had that patient, I would start with the upright chest, followed by the upright abdomen, because all I would have to do would be to change my SID and turn the patient around. And my last image would be my supine, because if they were out in the waiting room sitting in a chair, they've already been upright for the amount of time I need to layer everything out. So I would begin with those images. Some other names for things that they order, like an acute abdominal series, sometimes they'll call that a 3-way abdomen. And they can also order, sometimes referred to as a 2-way abdomen or a flat and upright abdomen. That is where you have one supine view of the abdomen and then one upright view. If the patient's not able to stand AP upright, then they would be able to do a left lateral decubitus on that patient. On this one, same thing. There is one routine for ambulatory and one routine for non-ambulatory. So a 2-way acute abdomen where there's a supine and an erect abdomen, you would begin with the erect abdomen. That way you've already met the time frame for things layering out, and we can tell that this patient has been upright because we see this distinct air fluid level line. And the way it is tells us that the patient was standing this way because air rises, so they were standing up for this image. I would start with that one, and then this one would be done second because the patient could lie down or would lie down for this supine abdomen. Right? You can barely see the top of the pubic arch, but that is perfectly fine because it is considered the inferior border of the abdomen, so that's acceptable. And according to the book, this is perfectly acceptable because we do not need diaphragm on a supine abdomen. It's only out in field that our radiologists tend to demand that if they're going to read an abdomen, they want the entire abdomen captured, which means from pubic symphysis or the superior anterior arch of where the pubic bones meet, all the way up to and including diaphragm. The AP supine abdomen, again, if they fit on one IR lengthwise, then the central ray for this would be iliac crest and midline, and your technique would be 80 kVp at 10 mass. On the erect abdomen, which would be one of the two done first, then you would have the patient upright. The central ray is 2 inches above iliac crest at midline, and your technique is just a little bit higher at 80 at 12.5. And all of these we would want to utilize left marker. The left lateral decubitus is done in place of the upright abdomen if the patient is non-ambulatory. And we discussed that this central ray is visualized incorrectly. It should be 2 inches above iliac crest at midline. And this would be a left lateral decubitus, but we would use a right marker. And the technique on that is 80 at 12.5 on the left lateral decubitus. Now, the PA erect chest in an acute abdominal series, that would be done first. You would be at a 72-inch SID, and your IR would be placed portrait or landscape, totally dependent on your patient's body habitus. You would have central ray at T7, which is found 7 to 8 inches below 7 to 8 inches below vertebral prominence, or at the inferior angle of the scapulas, and then midline. The patient, we would use left marker. We would have the patient take in 2 breaths, and on the second deep breath in, they would hold their breath, and our exposure would be 110 for the KVP at 1.3 mass. You would also have the patient with hands on hips, shoulders rolled forward to get the scapula out of the lung fields. All right, so before we look at the radiographs, let's kind of review, and I would write this down if you're listening, only because I don't have it in a specific order. So if they order a 2-view abdomen, a 2-view abdomen would mean 1 image would be supine and 1 image would be erect. You would begin with the erect abdomen, and then followed by your supine abdomen. If they ordered an AAS, or a 3-way abdomen, and the patient was ambulatory, you would start with the PA chest, followed by an upright abdomen, and then last your supine abdomen. If the patient was non-ambulatory, not able to stand up, then you would do an AP semi-erect chest. You would then do a left lateral decubitus abdomen, because that would take the place of the erect abdomen. And last, you would do a supine abdomen. So there's always 2 views of the abdomen, 1 view of the chest. It just changes a little bit if your patient is not able to your patient is not ambulatory. Same thing if you've got a 2-view abdomen and the patient is not able to stand up, you would do a supine abdomen and a left lateral decubitus abdomen. Lots of information, slightly confusing. The end of this is actually some radiographs to critique, so feel free to look through and see what the positioning error is on these. This scout, remember we talked about a scout image is done anytime that we give the patient barium or contrast media, then we take 1 picture of the abdomen to show what it looks like before we gave them contrast. All right, and with that, that ends this presentation. So make sure you write down any questions you might have. Make sure you bring those to class, and I will see you soon and we will discuss. Have a great day.